I'd like to welcome everybody to today's webinar, which is titled Proposed Changes to Macro, MIPS, and Meaningful Use, What We Really Think You Need to Know. My name is Scott Mash, and I'm here with my partner in crime, Kathy Costello. Today, we're going to be talking about, of course, macro, MIPS, meaningful use, but these are all portions of the regulation, portion of newly proposed regulations that include the MACRA rule, the physician fee-for-service proposed rule, the hospital inpatient, hospital outpatient fee-for-service, and then the hospital critical access hospital changes to promote innovation, flexibility, and improvement in patient care proposed rule. I'll warn you up front, we're going to go longer than an hour. We're going to try to keep the presentation to an hour, and then the questions, of course, will happen after the top of the hour. We do utilize the questions feature of GoToWebinar. So any point in time when you have a question, enter it, and then at the end we'll read them all. If you can't find the questions feature, enter it into the chat box and we'll find it. Handouts, if you go to the handouts feature of GoToWebinar, grab the slides. You can grab a flyer about a few future webinars that we've got rolling. I do want to let everybody know that there's just so much to talk about today with trying to align MACRA, MIPS, and these changes to meaningful use and a few other little tweaks that we had to pull out chronic care management and transitional care management. We're going to do a separate webinar next Tuesday that's going to focus on these rules. Kathy's going to handle this webinar herself because I'm double booked, but go ahead and get registered for that today because there have been some significant changes to CCM and TCM that make these programs much, much easier, and there's a few more dollars to be made there. All right, let's get started. We're going to talk about a few acronyms that we're going to use today, and some of these are actually acronyms that we've seen before, but they're going away. Meaningful use is being replaced by ACI, Advancing Care Information. Just point out a few more. Eligible clinicians is really replacing eligible professionals. Now it's a little more expanded. It includes PAs and a few others. But really the ones that we have pointed out here in red, the CPIA, CPS, QCDR, QPP, these are very important. Not that the other ones aren't, but those are included in the MACRA MIPS program. Okay guys, let's get into the meat of this. Let's talk about MACRA. MACRA actually, even though we saw the proposed rule dropped in 2016, it was actually in legislation back in 2015, which repealed this SGR, the sustainable growth rate is going away. MACRA is intended to be a merit-based incentive payment system, well, really MIPS is, and it consolidates several programs like PQRS, Meaningful Use, and a few others. It also developed alternative payment models. Now think of these as Medicare experiments to find a way to reduce cost while improving overall care. And these alternative payment models include things like the Microsoft Medicare Shared Savings ACOs. Now we have CPC Plus, the end-stage renal disease payment system, cardiac rehab incentive payment system, and we're going to see a lot of others. Yeah, the oncology payment system. We're going to see a lot more of these little, I call them, Medicare experiments. They're usually 3 to 5 years in length, but I think there's a lot of opportunity there. All right, so let's talk about the regulations that really lay out these next steps moving forward. So we saw the MACRA proposed rule drop on April 27th, and it's really a brand new approach. It sets a whole new foundation to pay clinicians. Really, it's going to move away from quantity and focus on quality and value.
Which is why they call it the Quality Payment Program. Everyone refers to it as MACRA, but the higher level and the way you see it in the regs is QPP, or Quality Payment Program, and that means either MIPS or APM. And I think it's important to keep that in mind, the difference between what's in the regs and what's in the statute. As we go through the presentation today, we'll make a point of telling you when something showed up in statute, because that is set no amount of change in the regs is going to change what was in the statute, but the regulation and the way that it's fleshed out are the areas that are still being worked on. So just keep that in mind as we go through.
Yeah, and really, again, in the QPP, in the quote-unquote macro rule, you have two major paths. You have MIPS, which really think of it as the heavily modified fee-for-service. And then you have the other arm, which is APMs, which is ACOs and other new payment models. So macro really, one thing it does is it sunsets several existing programs. So PQRS, the value-based modifier, and meaningful use. While they say they're sunsetting, they're really not going away. They're sprinkled now throughout the macro rule, and they have some different naming conventions for them. But it does retain a fee-for-service model. That's the MIPS track, but it is heavily, heavily modified. And of course, they're trying to support physicians who adopt these new payment models, these new delivery models, again, shifting away from quantity to quality and value. Now, participation in the new models is voluntary. You can, as I heard one organization say, you can ride fee-for-service to the grave. But I think there is a lot of advantages for adopting these new payment models. There are a lot of incentives to be made there. And, it really does, under some of these new alternative payment models, it really does provide a path for groups that truly embrace the concept to start delivering care in a whole new way and to try new things and really just see what works. Now, the comment period closed back on June 27th for MACRA, and then for the inpatient fee-for-service, the IPPS, it was on June 17th. And we did put together a team, which Ms. Kathy Costello led, and then included dozens of the groups we work with. I think we had a few folks from OHA and a few other of the big groups here in town. And we submitted those comments back on June 24th. There were 4,000 comments. We actually would go back in every now and then and see
how we had nothing else to do.
Oh,
we wanted to be amused.
Yeah, and we've never seen this many comments before. Some of these comments were hundreds of pages in length. Was it the Texas Health Association that kind of set up a program so folks could go in and enter a few things and it would do an auto submit? So there were like 1,000 from Texas.
Yeah.
But if you want good reading, go into the comments, look for the ones. You can actually submit these anonymous. Read those anonymous ones because
anonymous,
yeah, because there's actually some very good reading there, and those are generally the ones that I'll say are a little more harsh. But because of all these comments, all this feedback CMS is getting, now we are, the proposed rule states that 2017 is going to be your performance year that's going to impact your reimbursement in 2019. But the fact of the matter is there's so many comments, so much feedback, so much going on in the political environment, it's probably going to be delayed 6 to 12 months. So call Vegas, bet on a delay. But so what we think we're going to see in 2017 is kind of a middle of the road approach where the meaningful use changes, or the called ACI and MACRA, the changes that they're proposing there, we think we'll see those changes adopted in 2017, maybe a few tweaks to PQRS, and then a full adoption. My opinion is your incentive year, your measurement year, sorry, I couldn't find that, will probably be 2018. Again, that's just my feeling, but.
Yeah, and the reality is what we've seen since we talked to many of you after the MIPS regs came out is that CMS kept pushing out more and more regs, and they never made a point of the fact that the regs could address something other than what they were supposed to be. So we found several very important things for physicians that were in the hospital regs.
Yeah.
And so that's why we're so sure that they're going to take things by bits and pieces and kind of hobble them together for 2017, and we won't see a whole major reworking of all the programs until the beginning of 2018. But with that being said, we know enough about what's going to go on in 2017 that we want to talk to you about it. Okay, now in order to talk, and I recognize that we have people on both the hospital and physician side or ambulatory side on the phone, but the reality is, in this day and age, both sides of the table need to understand what the proposals are. And so, you know, if we get into a real technical area, especially on the hospital stuff, you physician people are just going to have to, you know, kind of amuse yourselves for a few minutes. But the reality is you all need to understand how this payment reform is going to work. So what we're talking about here, this model that's in front of you, is coming out of the MIPS legislation. So this is legislative. We know this is going to happen in the way that it's laid out here. What the regulations do is flesh out the particulars, and those percentages can change from year to year. But basically, the physicians who stay in a fee-for-service model are going to be weighted or measured and given a composite performance score, which is like your grade from the teacher, that combines 4 elements. It's going to combine meaningful use, quality reporting, resource use, which is, if you've looked at your group's QR-UR reports, which are cost quality reports, that's exactly what that is it takes the claims data from hospitalization and attributes it to providers, and then decides how much the care that is being provided for those Medicare beneficiaries you controlled and how well you did against national benchmarks. So that's the third area. And then the fourth area is this new clinical practice improvement area. And that is brand new. A lot of questions about that. I think that's one of the reasons why the MIPS regulations have been held up. But that basically is how it's laid out. This is statutory, so this will occur. Our only question right now at this point is what year it will occur and not whether it will occur. This new clinical practice improvement area, we set up an appendix because there was so much information on this. And the appendix has, at the end of the proposal, has all the various categories that are being used to judge what the quality of your practice is. So you can go through that. But basically, this fourth area is, are you pushing the policy considerations that Medicare has? So are you, the biggest categories are listed on this page, and it's, are you giving expanded practice like a PCMH would? Are you doing some type of population management, you know, as far as public health reporting, stuff like that? Are you doing care coordination? Are you doing chronic care management? Are you reaching out into the community using HIE or other ways? Patient engagement, big emphasis on patient engagement. Absolutely. And patient safety. The health equity is one, and the community involvement are ones that are new to what you see that we've heard for years that CMS is going to quantify this, and now they are looking at this, and that is, what are you doing in areas other than just the practice area? Are you serving specific populations? Are you like doing Physicians Without Borders? All that stuff gets weighted in now, or can get weighted in. Are you doing emergency preparedness? Are you one of the physicians who respond to that? Or are you doing behavioral health integration? Huge, huge priority for CMS right now. So those are the big areas that they're going to be looking at on how you're doing quality improvement. And then there's special rules for these on the right-hand side. You see these groups, the usual suspects, rural, less than 15, you know, specialty, PCMH. I mean, there's a whole list of things, and we are not going to get into the weeds on that until those rules become final, because
the weeds are different, aren't they?
The weeds are going to look real different. They've been cross-pollinated at this point.
Yeah,
so.
and really, when you see this list, kind of think about process improvement and business continuity in a very, very broad sense that in all, you know, of course, includes your patient care and your patient-facing issues, as well as the behind the scenes, the administrative. So it's such a broad definition
Yeah.
of what you can include.
A lot of questions about this, and so as I said, I think this slowed down the regulations, and we'll see how that gets filled out. The one of the things, though, it's not clear yet when this is going to take effect, but it's a huge, huge point that was made in the MIPS statute, and is one of the, I think, the best things about the regulation, and that is that they are looking at all this process by group, by practice, by TIN. And so what all of you have been doing, because I can see many of you as long-suffering people who have had to attest individually for 200, 300, 400 providers, recognize that there has to be a better way of doing it. And so this group attestation or group thinking on these various areas, be it quality reporting, which we know has been done under GPRO for a number of years, but the now meaningful use could be done as group quality reporting, the cost factors, and then this clinical practice improvement. So that'll be terrific when they get this together. This is one of those areas, because it has so much benefit, that I'm wondering if some part of this is going to be adopted for 2017, even if they push some of the other MIPS stuff off. Will they allow meaningful use attestation by group in 2017? So that's going to be one of the first things we look for when the regs become final. And whether or not it's popped into a smaller reg and pushed out faster is another thing to watch for. But the whole idea is that you will be able to report. You do not have to pre-register like you do now. Drives everyone crazy on having to pre-register for group reporting for quality metrics right now. You won't have to do that. The only two times when you're going to have to do pre-registration is if you're doing the CAHPS patient satisfaction surveys as part of your quality reporting. You still need to pre-register for that, because there's certain procedures that need to go into getting those established, or if you're using the CMS web interface. But I'm going to guess most of you will not be doing that, because there's a huge move in the regs to go to reporting through quality registries, which are either the specialty registries or the PQRS registries.
And a heavy focus on the QCDR format. Huge focus, and that's QCDR level 1.
Yeah, and we're gonna spend some more time on that, and we're gonna do a webinar within the next few weeks specifically on registries. So we won't talk about it so much here, but it's you need to know that whether MIPS comes in 2017 or 2018, you need to be strategizing what you're going to do for group reporting and who you want to go through. Because right now you will not be limited in the same way that you have been. There are all kinds of people who can accept your meaningful use, can accept your quality reporting, and do it all combined, or you can split that up. You can do your own quality reporting, you can do your own meaningful use and push the quality reporting through a registry. I mean, there's different ways of doing this, but that's one of the things you want to be looking at.
Yeah, and here's another reason that I personally believe we're going to see a delay is CMS had set aside a huge amount of money to build these reporting systems. Well, some of that got taken away thanks to the Zika virus. But I also believe that we will see a big shift to CMS using contractors, using many of what are the existing PQRS registries to build these entire reporting systems. So then CMS doesn't have to build these public-facing reporting systems. They can just work with these other registries. It'll make their life a little bit easier, but that's where I kind of believe the shift is going to go.
Yeah, and we'll tell you more about that when we do the registry reporting, but there's a lot of behind-the-scenes stuff going on with that is kind of an interesting picture of how quality reporting's been developed. So let's move on. We've got a lot to go through. Okay, on the EPs, or what are now known as ECs, once MIPS comes through, quality reporting may still be required as part of meaningful use in 2017. And the reason I say that is that one of the things we discovered in one of the other regs that have come out since the MIPS regs were proposed is in one little sentence in one of the regs, they were like, oh, well, one of the things we're doing is we're going to have the hospitals are going to do, in 2017, the hospitals have new measures, but the physicians are going to be reporting on modified stage 2 for 2015, 2016, and 2017. It's like, oh, really? You know, because here's this push on MIPS to say that in 2017, all these changes, and you all know what we're talking about, just tons and tons of change on meaningful use, going with changes in the measures, changes in the reporting mechanism, talking about base measures and super measures and blah, blah, blah. And all of a sudden in this, it actually appeared in the hospital outpatient rule, which just came out a couple weeks ago, that said that on the EP side, it's going to be 2015 to 2017. We're actually going back to what was proposed in 2015, which was the stage 2 modified rules. What we don't know yet, and we will have to wait and see, is whether they will adopt any of these other little proposed changes that were made to the measures that are being adopted for the hospitals, whether those will also be adopted for the physicians in 2017, or whether they're just going to hold meaningful use at exactly the same point where we started the process a year ago when modified stage 2 and stage 3 came out. So with that being said, we will have to wait and see whether you still need to do quality reporting as part of your meaningful use attestation. Medicaid, at this point, we won't know until the rule becomes finalized, because Medicaid never will commit to what changes they make until they have a final reg, which I can understand completely. The PQRS, this is another area where there were some very positive, significant things in the regs. So I would have to say this would be one of the areas that I could potentially see being pushed in 2017 without all the other MIPS falderall. That was, as far as the payment reform stuff, I could see this showing up in the final reg for 2017, because what was being proposed for 2017 in the MIPS regs is that the CQM reporting for physicians, which you all recall for PQRS, was 9 measures, and the proposal is to drop it to 6. And when dropping it, there would be no required domains for the meaningful use 543, and you wouldn't have to have it for PQRS either, but you would have to have, besides one cross-cutting measure, which is currently a PQRS requirement, you would also have to have one outcome measure. And we can go into that some more as the regs become final, because there's a whole lot of information about how they're resorting the CQM measures to make them easier to work with. The reporting period, regardless of how they go with this, whether they stay with PQRS for another year or whether they do a modified MIPS quality, is going to be 365-day reporting. And if you're part of Medicare Shared Savings, CPC Plus, any of these other reform models, you will do your quality reporting based upon those particular guidelines. Okay, one of the most common questions we have had is what's going to happen with the specialists. And when I say specialists, I mean those that we all consider hospital-based in the sense of their type of practice: anesthesia, radiology, and pathology, and some of the other subspecialties. Rather than, as has been done for the past 5 years in meaningful use, creating hardship exemptions by category for those specialties so you didn't have to specifically register for them, they're going to move away from categories of hardships by specialty. And instead they're going to replace it with whether you're a, quote, patient-facing provider or a non-patient-facing provider. And this has nothing to do with that little analysis we've done for years about whether a provider is hospital-based. That, you know, we just erase that from your mind right now. Because what they're going to do is sort out and call patient-facing encounters those that we normally think of as ambulatory, you know, E&M type visits, outpatient visits, surgical procedures or surgical visits. The newest area, though, where there has been a change in this is telehealth. Telehealth was never considered to be an ambulatory visit that you could count when you were looking at whether a provider is required to report under these new programs or under the old ones. Now they are recommending that telehealth be included in whether or not a physician is considered patient-facing in their engagement.
But that does, with the telehealth, it has to be two-way audio and video. So it can't be a phone call. It can't be a one-way video. It's two-way video. Think of Skype. Think of it's kind of a two-way Skype call. But that's really how they're considering telehealth. So it's really face-to-face because you can see each other.
Right.
So
sometimes good and sometimes not so good. But anyway, okay. So the other thing to keep in mind with the specialist area is there will be an exclusion created not based on specialty, but based on their billing. And what you're going to see here, and this is why I said you can't think just in terms of specialty now, but think about your business model. If you have a provider who bills 25 or fewer encounters under these patient-facing codes, with the ones that we just ran through, 25 or fewer in a given reporting period, they will be exempt from any penalties. They will, if you don't report for them, they won't receive any incentives, but they won't be penalized. So that's going to, again, I'm sure your business people will just be thrilled to find out that you have to run another report, but it's similar to the eligibility reports you've all done for Medicaid, only you're going to be using these codes that CMS is going to list. They're going to publish them every year, and you're going to have to run it against the codes. And
so really, it's under meaningful use. It was eligible providers. They looked at hospital-based, non-hospital-based, but now with eligible clinician, it's whether you see and touch a patient or whether you don't.
Right. And if they are a non-patient-facing physician, but they have more than 25 patient-facing codes, then they get thrown into the MIPS mix. And rather than being totally excluded, what happens in these areas is CMS with some, I don't know if it's a roulette wheel or if they have some other way of doing it, but they're going to weight, W-E-I-G-H-T, these physicians' measures differently depending on what they feel that particular specialty is involved. So if it's meaningful use, they may just weight it differently because, as we all know, these providers don't have some of the normal measures. If it's quality reporting, they may not have enough to meet the minimum threshold. So that's something we'll have to see how that's developed. I can see it as a whole specialty now of CMS's staff to figure out what they're going to do with non-patient facing.
But what we would recommend you guys do right now is look at your PAs who've always been exempt from meaningful use. You know, something you can do right now is start monitoring your PAs under the meaningful use program, because it's going to look, you know, it's going to look a little bit like that.
Yeah, and the nurse practitioners too.
Yep.
But anyway, this is one of the areas that I don't know whether this will be pushed in 2017 or 2018, primarily because we are at the limit of that 5 years of exemption for meaningful use. So they really need to make a decision about what they're going to do on the specialist for the coming year. Okay, now, here's our rewards penalties. We just want you to understand, and we're not going to go, again, into real depth here, But I do think everybody has to understand what we're headed towards about how your providers are going to be rewarded. For physicians who are strictly on the MIPS side, so they stay pretty much in a fee-for-service, and they do meaningful use reporting, and they do quality reporting, and whenever they're required to, they do this clinical practice improvement reporting, and they get all that in. Then the possibility of the incentives kick in, and it's going to start at 4%, and for the rarefied group that is like exceptional could go up to 14.5%. But keep in mind that any bonuses are offset by those who are being penalized. So
yeah, that's the problem with this program. I don't mean to say problem, but one of the downsides is because it's budget neutral, it has to be hard. There has to be losers so there can be winners.
Yeah, and so what you're seeing is those are the plus. Here are the penalties. If you have physicians that don't get reported or decide not to participate in MIPS and they're not part of a shared savings program or something else and don't meet those requirements, then these are the penalties. They're a little bit less now than what they are in this year if they are not doing physician or meaningful use and quality reporting. They're only at a 4% penalty in 2017, showing up in 2019, but it does go, look at that, it goes down to up to 9%. So, I mean, it's really something to pay attention to. And the same thing applies that has applied all along with penalties for RHCs, rural health centers, and FQHCs. They're not required to participate in MIPS for those areas that they bill under RHC and FQHC. The reward side, without going into all the rewards for these alternative payment models, there's just a couple of big things to keep in mind. Every APM model is going to have a separate set of rewards. You know, if you're in shared savings and you're able to save more than the 2% or whatever that CMS has as its threshold now, you share that savings. So those are separate guidelines for each APM model is going to have a separate way of rewarding providers who participate in that. What we're going to look at here, though, is what is happening under the MIPS MACRA APM model just for participating and being a successful, what they call advanced APM model, which don't get me going, but I mean, there's, oh my gosh, we'll talk about that when it becomes final. I'm so happy you don't have to do it today. But the reality is if you're an advanced APM provider, then without doing anything else, you get a plus 5%. So it's really important that when this does become final, we all understand how this works, because if you do it well, your physicians will get a 5% boost for a year in their reimbursement, in their fee-for-service reimbursement. But there's a lot of caveats there, but you still need to understand what's going on. You still need to do the reporting no matter which side of the aisle you're on, whether you're on MIPS or APM. But basically what it's going to look like, this is taken out of the QRUR reports as they appear now, and it's the value modifier program that's currently in existence. But we think this is what it's going to look like for that up to 4% positive, negative. It's going to show as probably a gradated +1, +2, +3, +4. We don't know that for a fact, or -1, -2, you know, down to -4, depending on how you rate against everybody else in the country who's participating in reporting, and that you're somewhere along that curve, and where you are along that curve is going to decide how you get reimbursed for the next year. So we just wanted to kind of get you to visualize how what is being done now is going to translate into this new reimbursement form whenever it starts, 2017 or 2018.
And just kind of as a quick side note, QRUR reports, your year-end QRUR reports for 2015, those are going to drop here in the next month or so. Download your QRUR report, your underlying data files. Take the time to sit down with the team and evaluate those. You've got to know now where your problem areas are.
Absolutely. Okay, to your favorite topic, you long-suffering souls who do meaningful use. I'm going to make Scott start this one.
Well, guys,
okay.
yeah, in the past, we would see from CMS, changes to meaningful use would drop in a single rule. So we knew to look for that rule, and we knew to look for changes to PQRS in the physician fee schedule proposed rule. Well, since meaningful use is coming to a close, and we saw MACRA, we're seeing a bunch of activity to align, to make changes with meaningful use and to align other programs with MACRA. So we list here a couple of the proposed rules that we're talking about. It's funny I say a couple, and there's four.
And
but
there's at least one other that we know of too.
Yeah, at least one other. So we're going to see a sprinkling of different rules. So why in the world do we have all these changes? Well, this is CMS's attempt to really say, okay, too much, too soon. Let's get refocused on patient care and start getting some rewards out there, some real rewards for quality. And CMS is really starting to listen to all of the associations, all of the comments, and they're hearing that the vendors, the EHR vendors, they can't keep up. Functions aren't working as they really want them to. People are putting workarounds in place, so they're really struggling with the technology. So we're kind of seeing things slow down and open up.
But the reality is,
it's an election year.
It's an election year. If you thought it was crazy on the political side, wait until you see what happens on the healthcare side.
Yep.
Because you've got to believe that Congress has had an earful about nothing more than they have over meaningful use and the changes in reimbursement and all this other stuff. So this is a high priority for them in an election year.
And regardless of which way the presidency goes or Congress goes, we're going to see more changes. As soon as folks get into their new roles, we're going to see more changes. That's just the reality. So let's start. Let's talk about some changes to meaningful use timelines. The big one for this year, 90-day reporting period. It's a 90 rolling day reporting period.
Not quarter.
Not quarter. It can be any 90 days. And your CQMs can be a different 90 days than your meaningful use period. If your first 90 days of this calendar year looks good, put it on the shelf. Print out all your reports, get your book of evidence together, be done with it, and then you can still focus on your CQMs and use the last 90 days of the year for your CQMs if those numbers look the best. Next year, they've modified some of the measures. We're going to see some lower thresholds, which we'll talk about here in a little bit. The hospital measures are different.
Talk about that.
Yeah, we'll talk about that. And so if you stay modified stage 2 in 2017, you're going to have a full year reporting. If I were a betting man, you might see 90 day for that too, but right now they're saying a year. And if you go stage 3, and again, the stage 3 measures in 2017 have been modified, that's 90 days. Out in 2018, it's full stage 3 requirements, but modified. Full year reporting, and CQMs are going to be submitted via eCQMs. Now, keep in mind that we're talking Medicare. Medicaid, we don't know what they're going to do yet, but we're going to see some divergence between the measures required under the Medicare program and under the Medicaid. I mean, I hope not, but the reality is we're going to see some differences there. All right, let's take a look at how the proposed rule will change 2016. Again, as we said, 90-day reporting period. But there's some craziness under the CQMs. For meaningful use in 2016, you can attest to your CQMs. There's one thing to note, that your attesting to the CQMs through the meaningful use program will not fulfill requirements for the Microsoft, why do I keep saying that? Medicare Shared Savings Program for IQR or PQRS. They will not fulfill that. You still have to do those reporting separately. Keep in mind, too, that this is the first year that hospitals are required to submit at least 4 eCQMs for quarter 3 or quarter 4. You cannot, you also during, when you submit those ECQMs, you still must do your chart abstracted measure. So it's not really taking anything away. My opinion, this is a CMS experiment to compare these ECQMs to what was previously done via chart abstraction.
Right.
So your chart abstraction efforts must continue.
Yeah, and we'll talk about that in just a minute because we're going to dig in on the hospital side here. But it's just important to note here that your ECQM submission hospitals for the 3rd or 4th quarter does not replace your chart abstracted IQR measures for that quarter, which answers the question that several of you have asked us when we've been out visiting is what if our ECQMs don't look good? Are we going to be judged, is it going to hurt our IQR score? And the answer is no. You should be submitting it even if they're really bad. Hopefully you're working towards, as Scott said, a better value, but the reality is that the IQR scoring is going to be done based upon your chart abstracted measures.
And keep in mind that, you got to get everything submitted for the Medicare program by February 28th. We've seen extensions of that in the past, but let's plan on getting it done February 28th. Medicaid, of course, always goes longer. So now we're going to go back to the hospital changes and back to Kathy.
Yeah, let's, as I said, I'm sorry if you're on the physician side, but it's not bad for you to hear this because the hospital area, believe it or not, is more settled than the physician reporting side, so we may have some lessons to be learned here. Okay, on the hospital side, the hospital, as we've said now, Scott had mentioned this, starting in 2017, no matter what happens with the MIPS timing, the hospital and EC or EP track is going to be separate. They're going to diverge. They're not going to look quite the same. And we're hoping that they stay relatively similar, but we don't know that for a fact. So we're going to have to wait and see that. But the hospital measures showed up in the inpatient and outpatient rules. Each had parts of meaningful use in it. And the funny thing is that CMS has bent over backwards not to refer to any of the ongoing programs as meaningful use anymore in these regs. And for the hospital side, they call it hospital EHR Medicare or Medicaid incentive programs. For the physicians, they call it, this quality payment program. And it's just crazy what they've done, or advancing care information or whatever. Yeah. So, but it's their attempt to move away from meaningful use because they took so much flack about it. But to me, it'd be better if they just standardized with what we've done in the past. But the one thing to keep in mind is that absent a pronouncement from Medicaid, the hospital, children's hospitals, will have a different attestation than all the rest of you. You Medicare hospitals will not have to do a double attestation because they're different, but the children's hospitals will have to pay attention to when and if MPIP adopts different measures for them. For the most part, the hospital measures are simplified. In 2017, these are kind of a amalgamation of everything that we've seen in all these rules. But in 2017, hospitals, if you're doing stage 2, and honestly, I'm really wondering whether in one of these rules they're just going to remove the possibility of doing stage 3 in 2017 because there's just been a lot of vendor pushback and stuff. Yeah. But right now, I'm going to say that most of you would most likely be doing modified stage 2 in 2017. And what this would look like if the rules go through as proposed is that you would have 15 rather than 16 CQMs to report on as part of meaningful use. We believe they're either going to be attested to or electronic, and that there would be a 365-day reporting period. The thing that throws the monkey wrench in on the hospital side for CQMs is their language in the proposed rule for what they want as far as ECQMs, because this year you had 4, unless you were CAH. For 2017, they're asking you to report, quote, all available ECQMs. What the heck does that mean? So that was one set of comments that went in is, please clarify what all available means. So we'll have to let you know what they mean, whether it's just wherever you are in the build process or whether you're going to be required to build as many as possible and then report on them. 13 ECQMs are being removed from reporting. We'll show that to you. I think what Scott was saying earlier about what CMS is trying to do to compare hospital and physician or hospital chart abstracted measures versus ECQMs is true, because they're going to take a random sample of 200 hospitals, won't you be lucky if you're part of that lottery, for validation of your ECQMs, and they've even allocated money for it. So I think that is going to happen. And CMS is asking for comments on new ECQM fields. The other thing that's different about what they're doing on the hospital side is NQF is conducting a 2-year study about including socio-demographic factors as part of CQMs.
Yeah, and also, if you have not at least thumbed through the hospital outpatient proposed rule, I would suggest you do, because there is mention of ECQMs for your OQR measures, and there's a proposed measure out there listed for it's for opioids, and it's an opioid-focused measure that they are proposing as being one of the new ECQMs for OQR.
Okay, so basically, the modified stage 2 in 2017, they're proposing 2 deletions, 1 clinical decision support and 1 CPOE. And this had originally been proposed in 2 separate regs for both the hospital and physicians. We don't know what's going to happen on the physician side, whether or not you're going to have to report on these 2, but definitely on the hospital side, if it goes through as proposed, you will not have to report on CDS or CPOE next year.
Now,
this year you do.
Yeah, keep in mind, though, that they are deleting these measures from reporting. These are still required functions within your EHR. They're you just don't enter them during reporting anymore.
The other thing that kind of changes the modified stage 2 is the view, download, and transmit, which was supposed to move to 5% in 2017, is going to stay at 1 patient. So I think that was good news for everybody.
Absolutely.
Okay, we won't run through it, but here's the list of potential deletions for CQMs for 2017 for the hospitals. Here is the list of ECQMs that they're proposing to keep for 2017 reporting for the hospitals. If you decide, and if it is still an option for 2017 to do stage 3, as I think you recalled, the stage 3 measures would be 2017 90-day reporting as opposed to the proposed 1-year reporting in 2018, which, as I said, we'll wait and see. I'm really wondering if we're going to be looking at 90 days over the next couple of years. The CDS and CPOE would continue to remain being removed from the stage 3 as it is proposed for modified stage 2. The other changes were to really lower the thresholds for the hospitals, because the hospitals are going to stay with thresholds, unlike the ambulatory providers. So the 2 things that I think are important to keep in mind here is secure message, which we all know was not ever intended to be a hospital measure. Are you emailing your patients? It's going to stay at 5% for both 2017 and 2018 instead of rising to, I think it was 35%. The other thing that is different about what they're proposing for ongoing stage 3 is that what was going to happen in 2018 for the electronic summary of care being sent to your transitions of care measure, which has been 10%, was supposed to go to 50% in 2018, and that is going to stay at 10% under the proposed rules. Okay, and the request accept patient records for transitions of care, I think was supposed to move to, if I'm not mistaken, 40% in 2018, and that also is going to stay at 10%. The other big change for you all, because I know it's caused a lot of questions, is that public health reporting, which originally in stage 3, you were supposed to pick up a 4th public health or clinical data registry reporting requirement as a hospital. They are proposing to remove that 4th requirement, leave you with the 3 that you currently have, which is syndromic, immunization, and ELR. So I think that's good news. We can talk as things move along about use of data registries for other purposes, but for meaningful use, you will not have to do a 4th report.
And remember, those on the phone that are on the EP side, syndromic surveillance is going away as an option for all providers except those working in the urgent care setting.
Okay.
Yeah.
We're moving. Scott's going to walk you through this because, again, this is an area that we've gotten a lot of questions on. What's happening with the appropriate use criteria for diagnostic imaging? And even if you are not in a hospital setting, this does pertain to physicians in the ambulatory setting, so it is something you want to be aware of.
Yeah, and this actually, there was a brief mention in the hospital outpatient and hospital inpatient side, and they really refer you over to the meat of the rule, which is in the physician fee schedule. Oh, sorry. All right, so first let's talk about what is an AUC. Well, it's a clinical decision support rule that's really intended to assist clinicians in selecting an imaging study that's most likely to improve the health outcomes for patients. That's the CMS definition. Let's jump down to bullet point 3 to say what it really is. It's really an effort by CMS to find a way to lower cost without negatively impacting care. And, maybe some of the appropriate use criteria really will help improve outcomes. It was first mentioned in the Protecting Access to Medicare Act in 2014. Then it was really introduced on the physician fee schedule in 2016. So again, an AUC is a clinical decision support mechanism, they're using the term CDSM, that presents to the ordering physician during the ordering process to determine if an advanced imaging study meets the defined quote-unquote appropriate use criteria. It originally was proposed to present for every advanced imaging study, but they've gotten feedback from a number of developers that it's way too broad, so they said, okay, we're going to back it off. We're going to focus on some priority areas, which we'll look at later. The appropriate use criteria is going to be developed by what they're calling a qualified PLE, which is a provider-led entity. Probably the best example is the American College of Radiology has spent a ton of time on this. There are other groups. Now, the difficulty there is that these different groups could have different sets of appropriate use criteria. Developers can use any of these appropriate use criteria that are developed by the PLEs. The CDS rule, or the appropriate use criteria CDS rule, must be integrated into the clinician workflows. So this was originally going to be required for any ordering provider by January 1st of 2017, but it's been delayed. And at the very, very earliest, we're going to see it as a mid-year requirement in 2017, and again, that's at the very earliest. And then we'll see the procedures for capturing this information on claim forms, and there will be some reporting requirements. We're going to see that in the physician fee schedule next year, in the next cycle of fee schedule. So this time next year, we're going to know what's required there. Also, that we may see an expansion of the priority areas that are going to be required now. And if they do that again, we'll see it in next year's physician fee-for-service schedule, and those priority areas will not take effect until January 1st of 2019. So now we're going to look at the specific requirements of the appropriate use criteria CDS. And again, it must be integrated directly into the ordering provider's workflow, and it's meant to facilitate evidence-based care delivery. And it's going to more or less, it's going to function like a pop-up. It's a clinical decision support rule. It's going to kind of be like a pop-up, and it's going to look at certain things within the medical record. It's going to look at the patient's problems, some other data, and see if that specific imaging study that was ordered is consistent with what is defined as the appropriate use criteria. It's going to provide immediate feedback to the ordering provider that includes documentation, the full appropriate use criteria with some citations back to evidence-based care. And if that study meets multiple appropriate use criteria, all of the supporting documentation for all of the appropriate use criteria must be presented. Now, the original intent was that the CDSM, the Clinical Decision Support Mechanism, be integrated directly with the EHR. Vendors are struggling. So now they are opening this up a little bit to say, okay, it can be a cloud-based application. It can be a standalone product, or it can integrate through an API. It can be a third-party product integrated within your EHR, though they really would love to see the EHR vendors really build this into the ordering product. And again, the appropriate use criteria must be from a CMS-defined provider-led entities. Developers, they just can't write these applications. They have to be CMS approved to write the application for the CDS mechanism. Some other requirements is that the appropriate use criteria must be updated no less than every 12 months. They would like to see it more often, but the floor is 12 months. And if an AUC is determined to be potentially dangerous, or if there's an error, there must be a process to go in and either mark it as inactive or make a change. The system must also record that the CDSM was presented, the response of the provider, and there's some information that's going to have to drop to the claim form, but that really hasn't been defined yet. So let's take a look real quick at what they've defined as the priority areas. There are 9. So the appropriate use criteria CDS mechanism will present for all advanced imaging studies for chest pain, abdominal pain. You guys can see the list here. We're going to see this list expand over time. Now we're going to shift to something that was mentioned in a very, very small rule that came out. It's like 4 pages. The hospital critical access hospital changes to promote innovation, flexibility, and improvements in patient care. That's the name of the proposed rule. They stuck in a little section in there that focuses on your quality and process improvement. And what this does is this proposed rule requires that your hospital-based QAPI, your quality and process improvement programs, must now incorporate all available reporting mechanisms, patient data, or any program that you report quality information to has to be, the QAPI folks have to be at the table. So if you have this includes meaningful use. So get your process improvement teams at the table for meaningful use, for your IQR, OQR reporting. If you're a health system, this probably means they need to be at the table for PQRS, and they're going to need to be at the table for MACRA. This, because remember your MACRA rules, you've got those eligible clinicians, which are hospital, what we would normally think as a hospital-based position. So again, this was an easily missed rule, and we think it's worthwhile that you go and read that. And there may be a slight different interpretation on it, but the way I read it, they have to be at the table. Also in the physician fee schedule rule, another thing we thought that was worth mentioning is what CMS calls the payment incentives to transition to digital x-ray. And I put incentive in italics because I couldn't find the incentive. All there is a de-incentive. It's a penalty. So your incentive is don't be penalized. And what this requires is they want to go away from film. So starting in January 1st of 2017, if you submit a claim form for the technical component of an x-ray, and it's film, they're taking 20% off the top. Now, out in 2018, what a lot of folks did to transition away from film is they went to kind of it's called computed radiology. Really what it does is it takes the film cartridge and replaces it with a digital cartridge. Well, that's a good system. It's really not full digital X-ray. So starting in 2018 to 2022, if you're using computed radiology, again, cassette-based imaging that utilizes imaging plates rather than film, they're taking 7% off the top. Once you get out to 2023, they're taking 10% off the top. So starting in calendar year 2017, you have to tell on yourself. If you're still using film, you have to put an XX modifier on all those claims, so then Medicare knows to put the penalty in place. Back to Miss Kathy.
Okay, since we're running long, we're just going to keep it at a high level for the physician side because we honestly won't know when MIPS comes about. But let me just say the biggest change from the meaningful use side is we will not have thresholds on the ambulatory reporting. It will be kind of you get 50% if you report on one patient for each measure. And then you get progressive grading for, how well you do in each category. And we'll have to see how that gets refined in the final rule because there were some questions about how that looks at things. The other thing Scott had mentioned, but we need to watch for this, is there is a requirement that nurse practitioners and PAs be included in your meaningful use reporting, in your other reporting in 2017. But if MIPS is pushed off until 2018, we may not see that take effect until then. We'll just have to see. Then the other area is we do not know how they're going to reconcile the difference between Medicare and Medicaid program. The good news, though, as we had said, is it looks like you can do group reporting. For all ambulatory providers in 2017, the proposal right now is to go back to our modified stage 2 measures. What that does not tell us is whether on the physician side, like the hospitals, will be doing one view, download, and transmit and one secure messaging, or whether we revert to the full modified stage 2 that was pushed through in 2015 where it's 5%. So again, let's look at that when the rule becomes final. And the other note is that all numerators must be calculated during the calendar year. Remember, we had a period where you could still be adding stuff before you attested, but after the calendar year, and that's not going to be true now.
And just a reminder for your security review must be completed by the date of attestation or the end of the calendar year, whichever comes first. And that's true on the hospital side or the physician side.
Okay, if you providers who are in an ACO, please note there is going to be a change, and I do think that this will go through for 2017, that right now you are being weighted and graded on your primary care and the percent of primary care practitioners in the ACO who are meeting meaningful use. And what's important about that is it's the only ACO measure where you get double the points if you're 90% or above. What is supposed to happen under the proposed rule is that is going to be expanded to include meaningful use for all providers, so keep that in mind if you don't have your specialists implemented yet. And again, we'll have to see whether this begins in 2017 or 2018, but I would take this as a given. The other thing is that is not clear whether it's going to come in 2017 or 2018 is group reporting, reduced quality metrics, and deletion of CDS and CPOE on the physician side. So as is noted by such fine people as Yogi Berra, it ain't over till it's over, or it ain't over until the fat lady sings. So who knows? Come back and join us again when the rules are released, in probably late October. But this is what the physician reporting is going to look like right now if we revert to modified stage 2 for 2017. And as I said, we'll just have to see what they do with secure messaging and view, download, and transmit. I'm going to guess that they're going to keep it in line with what they're doing with the hospitals, and that it will only be one patient but let's wait until we see it in writing. The MIPS generally is, you know, we won't even go there until we see what the final is. For 2017, if you're doing stage 3, which I'm not sure is going to be an option, if it's a new provider, they're already not going to be allowed to do stage 3 in 2017. But if it is, we're looking at the same measures that we were looking at under the stage 3 rules last year, with the addition of these measures here. These are the new stage 3 measures. And we're just going to have to see how that works on the physician side, if they're going to stick with a threshold or totally move out of the threshold when they rewrite the MIPS reg, which I think is the intent because that was in the legislation. The issues that still need to be decided that will affect all of you is there a low volume threshold for your physicians doing meaningful use, and whether or not it's going to be a dollar-based or an encounter-based number. Right now it's supposed to be both. Clinical practice improvement, a lot of work still to be done on that. Yeah, a lot of clarification. APM models, there's still a lot of questions about the risk bearing and which groups are going to be risk bearing under those models.
And I would challenge anybody to, in 2 sentences, define a next generation APM.
Yeah, really. And then the specialty area, there's supposed to be this physician-focused payment model technical advisory committee. Don't you love that name? That's supposed to be looking at new specialty APMs, and so far, at least as of 2 months ago, I think they had one organizational meeting, and they're supposed to be making recommendations by November. So again, that's probably pushed off for another year. But one of the biggest issues is coordination of Medicare and Medicaid meaningful use, and we'll just have to wait and see in the final draft. So with that being said,
yeah, we did include an appendix just of stuff that we knew we couldn't get to, and to provide you some more details. We want to make you aware that we do have some upcoming webinars coming up, and we're going to move to questions. Now, give me a second here. I got to pull up our questions, and this will also give you a minute or two to go ahead and enter your questions. Okay, here we go, Miss Kathy. You go to the top. You ready?
Yep.
Is the 90-day reporting period for this year official now?
Well, no, it's still, it was one of the proposals. I think it was the inpatient or outpatient.
That was in the outpatient.
Outpatient rule.
Yeah.
And so we're going to have to wait, but the outpatient rule, unlike the MIPS rule, has had fewer challenges to it. So I do see that probably becoming final, maybe as early as the end of this month, but most likely in September.
But in past years where we have seen a 90-day rule in a proposed rule, that's something that CMS never takes away. So that's one we know you can take to the bank. Take to the bank, it's 90 days.
Yeah, and we should know, hopefully, within the next month and a half on that.
Next question, does ECQM submission need to be for 90-day period also? Isn't the main idea to test and validate the data process?
I'm assuming they mean for physician ECQM.
Yeah, that one I don't.
Yeah, I believe it is for 90 days also.
Pretty sure that one is.
Yeah, I'm sure that we saw that, but we'll double check that and put it in the email going out.
But on the hospital side, it's third or fourth quarter. It's not 90 days. It's by the quarter.
Yeah, and I think the ECQM one was any 90 days, because remember last year there was that big controversy about whether you could use any 90 days for your CQM. So this year they clarified it could be any 90 days for both ECQMs and CQMs. That I remember because of the controversy.
Yep. Next question. For PQRS measures going down from 9 to 6, do you know if we are in an ACO, if that's also the case? And the answer is no.
No. Well, and see, that's what we're saying. This is one of the areas they need to clarify, because if you're in an ACO, this is the last year of traditional meaningful use reporting. So this is the last year you would have the question of submission of quality measures different. So in 2017, you most likely are not going to have any separate CQM reporting. It will be strictly through the ACO, and so it'd be the 30, whatever you all are up to, 34, 35, depending on how you count it, would be your CQM measures, and you would not, at least for the providers that are part of the ACO, do a separate submission. But that is very tricky as to how that's handled. So let's look at that again when the rule becomes final.
I saw the reporting period for 2018 says 1 year. Any word if they're looking at that being 90 days? Now, we're hearing rumblings that 2017 may go to 90 days for those following modified stage 2. It's already, for those that are going to take a run at stage 3, already 90 days. 2018, who knows?
I'm going to guess, honestly, that what's going to happen is when stage 3 comes about, that maybe the first year of stage 3 will be 90 days, whether that's 2017 or 2018. But after that, they're probably going to want to see a full year, because by that time they are hoping that all the technical challenges will have been addressed. We all know you are in the process of doing upgrades. Many of you are changing systems totally. And so I see the next 2 years as being very fluid. But after that, especially as people all get on stage 3, I'm going to guess it's going to settle down.
Yeah, and also remember in 2018, if, MACRA's in full effect, only the hospitals will really be reporting for meaningful use. It'll be a MACRA ACI measure at that point, or who knows by that time. So will MACRA MIPS and meaningful use proposed rule not take effect as earlier as planned, but you're saying we should still be ready just in case?
Now, what we're saying is the proposal, as far as it affects meaningful use, is they very clearly have put meaningful use back into modified stage 2 for 2017. But all that other stuff, the quality reporting and the question of reducing the number of reporting metrics, and the question of using CPIA, that clinical practice improvement, all that is what I call hardcore MIPS stuff. And that's the stuff that I think we just have to wait and see. As I said, I think it would be a good idea if they reduce quality reporting in 2017 from 9 to 6, because that's really a separate issue from meaningful use. But whether or not they do that just depends on how jaded everyone's become by the end of this year.
All right, please clarify the time frame for the security review. All right, the security review, regardless of your 90-day reporting period, your security review must be completed sometime between the beginning of the calendar year and the end of the calendar year, or the date of attestation, whichever comes first. So in theory, if CMS opens the attestation portal in November and you say, hey, November 1, I'm going to attest, your security review must be done. Also keep in mind that every year you must have a separate and distinct security review. Now an update to a previous year's security review does count as a separate and distinct, but make sure you also have that mitigation list.
Yeah, but as far as your 90 days, you do not have to have your security review run in those 90 days that you're using for your attestation period.
For EH, in 2016, 90 days goes into effect. When do you see that we can attest? When do you think the software will be available? I really hope, because really the only meaningful change we're seeing this year is a modification of the reporting period, and it just so happens it was the same reporting period we had last year. I've got my fingers crossed that when this rule becomes final, that they'll open the attestation portal so folks can get this on the books for this calendar year. But again, last year we didn't see that.
Yeah, and some of the reasons they do that has to do with payments, but we all know how slow CMS was on payments this year. So, if they would open the attestation in November, the payment would still show up after the first of the year. So I'm hoping maybe they'll complete the process.
That is our last question, but I would like to thank Ms. Kathy Rich. We give her these slides, and Kathy and I put them together so quick, we don't proof them. They're ugly. She transforms them into the presentation that you guys saw here. She puts together our handouts, and she puts up with us making changes until 5 minutes before the webinar. So, Kathy, if you're listening, We truly,
Thank
truly
you.
appreciate your effort.
Thanks all. We're so glad you joined us, and watch for another presentation. We've got several coming up, but when the rules become final, we obviously will dig into them more.
And sign up for Dottie's newsletter. We try to announce our webinars through the newsletter. We've had some that have popped up prior to a newsletter coming out. Go to clintusync.org, sign up for Dottie's newsletter. It's got great information. Our emails are here. I'm guessing everybody on this webinar already has Kathy and my contact info. If you have any question, you need clarification, email us will help you out. Thank you so much. Enjoy the rest of your day.
Bye.